Good evening, everyone. My
Uh,
name is, hello?
doctor, yes, doctor. Just give me a minute. I'll introduce you.
Okay, sorry.
Hello, everyone. This is Archana Madhasu from JNTU University, India. I'm going to moderate the virtual session of the Day 1 program. Now, I would like to announce our virtual presenter, Dr. Elena Canazzi from Spedale Civil Brescia University Affiliated Hospital, Italy. Dr. Elena, now you are
Thank,
welcome to start your presentation.
thank you very much. Thank you. Good evening, everyone, and thank you for the invitation. Unfortunately, I cannot see you at the moment. I'm talking from Italy, and now here is 10 to 11 p.m. Yes, my name is Elena Cagnazzi. I'm a medical doctor and an anesthesiologist, and I work in this hospital that you can see on the screen is a university hub hospital with roughly 1,500 beds and 22 operating theaters. We are performing roughly 13,000 operations a year, and my hospital is in the north of Italy. I'm here today to speak about this study. It's a WOC videolaryngoscopic intubation, a case series. This is a study registered at clinicaltrial.com, and I'm the principal investigator in this study, and I'm the one that introduced the awake videolaryngoscopic intubation in my hospital, and I'm responsible for safe anesthesia in obese patients in my hospital. The study has been conducted in Spedale Civili Brescia from January 2019 till November 2021. The setting is operating theater, different specialties, and we have enlisted 27 patients that were awake intubated for elective or urgent surgery. I'm aware that my topic is a bit of an anomaly in this session. However, I hope this may help in understanding other important elements related to obesity, like, for example, the difficult airway management in these patients. And here my summary, I'm going to talk about the devices we anesthesiologists use to handle every day in theater. And I'm talking about the routine airway management and about difficult airways and obesity, and why do we need awake intubation. I will show you the awake intubation procedure, and at the end, some results and conclusion. Here, I want to show you the device system. As you can see here, this is a med that does not stay for crazy, but is just the name and acronyms for mucosal atomization device. This is a device really important in order to administer properly the anesthetic into the oral cavity of the patient. We have to administer it very carefully on the tongue of the patient and on the pharynx pillars and on the hypopharynx. And later, in a way that I will show to you, we have also using this device to administer the anesthetics in the vocal cords and in the trachea of the patient. And this is really important in order to avoid gag reflex and in order to avoid coughing reflex. Here you can see the old and traditional Macintosh direct laryngoscope. It was invented in 1943. It has no camera, but it has a light here on this part of the laryngoscope that is named blade of the laryngoscope, while this part here is the handle of the laryngoscope. Here down in the bottom part of the screen, you can see a couple of orotracheal tubes, and on the right part of the screen, you can see here the Gliscope videolaryngoscope. Here we have the videolaryngoscope blade, and here we have the a light, but also a camera. Therefore, we are going to see the vocal cords of the patient on a screen. And here in the bottom part of the screen, you can see the video bronchoscope. This bronchoscope is one of the bronchoscope available on the market. Here the bronchoscope has a kind of stylet that we not only we use these in order to visualize the vocal cords of the patient, but we also use these like a kind of guide to let the tube goes down into the patient trachea. And I want to talk you about I want to talk you about the routine airway management. Usually, the patient initially needs to be pre-oxygenated, and this is really important, and we have to do this procedure always. After the pre-oxygenation, we have to administer general anesthesia, and then we have a brief period of apnea. This is named the safe apnea period, because in this brief period we are not having any kind of oxygen desaturation. And after this period, we have the intubation. In the bottom part of the screen, I'm going to show you instead the awake intubation procedure that is different, because we are pre-oxygenated the patient as before, but then the patient is awake and is maintaining his spontaneous breathing. We have to intubate the patient, and only after the intubation we are going to administer general anesthesia. And therefore, in the awake intubation procedure, it's really important to maintain this spontaneous breathing, and therefore it's really important to use drugs able to maintain spontaneous breathing, or to use a proper dosage of drugs in order to maintain spontaneous breathing. Awake intubation is the gold standard for predicted difficult airway, but despite this, is underused. And also in morbidly obese patients, this procedure may be useful, because morbidly obese patients, they are more difficult to intubate, more difficult to ventilate, and also their rescue maneuvers may be more difficult. In this kind of patient, it's really important to manage them in high volume bariatric centers, or at least in centers that have at least 100 cases per year. It is important to have a protocol to manage the airway of this patient. We are now back to the routine airway management, and I'm talking now about the incidence of difficult intubation. Nowadays, the anesthesia and airway management are really safe. Despite this, we are still having a small incidence of difficult tracheal intubation. We have a 6% of difficult tracheal intubation in general population and 16% in morbidly obese patients, but with the traditional laryngoscope. While if you look at the bottom part of the screen, you see that with the videolaryngoscope, the incidence of difficult tracheal intubation is much lower, 1.4%. But in order to maintain this really low incidence of difficult tracheal intubation, it is really important to assess properly every patient and to assess them beforehand. Therefore, here I want to show you a tool that we have in order to assess the patient. This is the Elgan-Zuri Risk Index. Is a score that goes from 0 to 12. And in this score, we have 7 parameters that they are anthropometric parameters. And if the patient is having 0, it will be easy to intubate, while if the patient is having 12, it will be really difficult to intubate. Thanks to several studies, we now have a threshold to use in order to schedule patient for general anesthesia and tracheal intubation, or to schedule them to awake intubation. Because if the Elgan-Zuri risk index is 6 or lower, we can schedule him or her for general anesthesia and tracheal intubation in general anesthesia. While if the Elgan-Zuri risk index is bigger, is 7 or bigger, or in case of any anatomic abnormalities, like for example a neck mass or previous laryngectomy, we have to schedule him for awake intubation. Of course, here we have a difference because when we are in the right part of the screen or in awake intubation, in case of failure of the awake intubation, there are no risks for the patient because he is spontaneously breathing. The awake intubation procedure can be performed both with a videolaryngoscope or with a video bronchoscope. But I want to focus on the fact that nowadays every anesthesiologist is very confident in using the videolaryngoscope, and therefore this can be a tool for the daily management of the airway in general anesthesia or in the awake procedure. Now I want to talk about the difficult airway and obesity. And here I want to remind you that a report from the UK found that major complications related to airway management were twice as likely in obese patients compared to general population. And now here I want to list to you only some of the pathophysiological alterations that give us this high complications rate. You all know that the neck circumference in obese people is increased, and also we have an increased waist circumference, and this leads to a reduced residual functional capacity. And this is a first reason to have a short safe apnea period in this patient. A second big pathophysiological change that we have in obese patients is the obstructive sleep apnea syndrome. Really often this syndrome is not diagnose when we see the patient, when we assess the patient in the anesthesiology visit. And therefore, this obstructive sleep apnea syndrome is able to the oropharynx of the patient became edematous, and this is a reason for difficult intubation and difficult ventilation. Therefore, here I have listed several reasons that leads to a shorter safe apnea period. And when we are evaluating the patient and we recognize that this safe apnea is shorter than normal, we have to consider awake intubation. Again, how can we prevent airway-related complication in bariatric surgery, but generally in obese patients? We have to assess them beforehand. We have to remind that we have managed this kind of patients in a high volume center. We have to assess patients and to select some of them for awake intubation procedure. We have to treat comorbidities, and especially we have to look for others. We have to ask for polysomnography if this condition is suspected but not diagnosed yet. And we have to start CPAP treatment before surgery, 6 to 8 weeks before surgery. And this is for safety reasons and for reducing perioperative complication and intubation complication. But what we have to do the day of surgery, if we have well prepared the patient, we have few things to do the day of surgery. It is really important the position of the patient, because as you can see here in the bottom right part of the screen, we have to position the patient in a head-up position. This is a really important position for this patient, because with this position we can move the soft tissue and the dry diaphragm down. The diaphragm goes down, the residual functional capacity increase, because we have more alveolar available for the pre-oxygenation procedure, and the safe apnea in this way increases. So we have to position the patient, we have to pre-oxygenate the patient with a end-expiratory positive pressure. We have to have an airway protocol and to use routinely the videolaryngoscope. And we also have to remind and to consider always these patients at risk of aspiration. And that's why again, the awake intubation procedure is useful in order to avoid aspiration. And instead, when we are choosing the general anesthesia, we are using another technique to avoid aspiration that is named rapid sequence induction. Here, I want to show you the inclusion criteria we are usually that we are using in our national and public health system. The patient can be scheduled for the patient can be scheduled for bariatric surgery if the body mass index is higher than 40 plus several attempts to lose weight, or if the BMI is higher than 35 plus comorbidities plus several attempts to lose weight. In this case, the surgeon can schedule or can give the indication for surgery. But after this, the patient needs to have 3 mandatory visits: the anesthesiologist, and the anesthesia visit, the dietitian visit, and the psychiatrist visit. every doctors, every one of these doctors have to exclude uncontrolled pathologies. The anesthesiologist needs to exclude, for example, untreated sleep apnea syndromes. The dietitian needs to exclude uncontrolled eating behaviors, and the psychiatrist needs to exclude uncontrolled psychiatric disorders. And in case of 3, okay, the patient can go to the surgery. And in case we have an untreated pathology, we need first to treat the pathology, and then the patient can go to surgery. So now we have understood that despite the fact that anesthesia today is really safe and intubation is safe, but we still may have complications. And despite the fact that these complications are really rare, they can be life-threatening. And that's why we still need the awake videolaryngoscopic intubation procedure. And now I'm going to show you this procedure. And here I'm going to show you these 6 phases procedure. I decided to divide into 6 phases this procedure in order to make it easily replicable by other anesthesiologists. I'm going to show you the first 2 phases, and then I'm going to show you the other 4 phases thanks to a video. In T0, we have to both start the dexmedetomidine administration, endovenous administration, and to start local anesthesia administration in the oral cavity, tongue, pharynx, and hypopharynx. Then in T1 phase, we have to do a really important maneuver because we have to administer local anesthesia, but then we have to check that the gut reflex has disappeared. And this is really important for a comfort maneuver for the patient. Now I'm going to show you this video. Here we have a patient. His BMI is 37. Is the patient scheduled for a thyroidectomy? And this patient has already been prepared because in T0 he had received dexmedetomidine 110 micrograms in 20 minutes. In T1, I've done a retropharyngeal manual exploration, and he had no gut reflex. In T2, he had received fentanyl 50 micrograms, and now I'm going to start with the video so you can follow it. Now I'm in the T3 phase. Here I'm doing the videolaryngoscopic, the first videolaryngoscopic exploration, and I am administering local anesthetics directly, thanks to the MUD device, directly to the vocal cords and the trachea. It's really important to administer the anesthetic into the trachea in order to avoid any coughing reflex. And here the patient is talking to me, and I talking to the patient in order to continuously check his level of sedation and to check that he is spontaneously breathing. I'm now waiting that the anesthetic takes effect, and so I'm waiting few seconds, and now I'm going to the T4 phase, that is the videolaryngoscopic intubation. Now the patient is telling me that his nose is itching, and I'm helping him. And now, as you can see, he's going to spontaneously open his mouth in order to allow me to perform the videolaryngoscopic intubation. As you can see here in the screen, I'm going to see his epiglottitis, and this is the epiglottitis, and under the epiglottitis, I'm seeing his vocal cords and also the trachea. As you can see, he is no gagging, he's not coughing. This is really important in order to safely complete the maneuver. Now, as you can see, the tube is inside his trachea, and now I'm going to T5 phase, in which I'm connecting the orotracheal tube to the breathing machine, because I have to check that the tube is correctly positioned, and I have to do it checking the CO2 curve. Okay, now I'm going to show you some other results, and here in this table, I just want to focus on the second row, and here, as you can see, here we have the reason for awake intubation. As you can see, we have several pathologies, but here in the second row, we have 5 morbidly obese patients. Their BMI was going from 42 to 78, and this patient with a BMI of 78 was a patient of 595 pounds and was scheduled for a gastric bypass bariatric surgery. Then here I want to focus on the drugs dosage. As you can see here, in T0 phase, we have administered dexmedetomidine, both with or without ketamine. And I want to show you also the dosage. In this case series, we have administered 1.5 micrograms per kilos, and I'm talking about adjusted body weight and not about real body weight. As you can see, the patients have received also other kinds of drugs. And here I want to conclude my presentation with few key points. I want to share with you 7 key points. First of all, the first point is safety. Dexmedetomidine combined with other drugs, like for example fentanyl, preserves spontaneous breathing and cooperation. The second point is that we introduce a new dexmedetomidine dosage, 1.2 to 1.5 micrograms per kilo adjusted body weight over at least 15 minutes is satisfactory for this invasive procedure, that is awake intubation. The third point is replicability. These 6 steps, preparation and intubation procedures, transform awake intubation into a routine procedure. And the other points are all about obese and super obese patients. Obese and super obese patients can be safely intubated also in general anesthesia, especially in a high volume center. We have, for safety reason, they have to be well prepared in advance before surgery, and especially obstructive sleep apnea syndrome needs to be treated before surgery. The 6th point is that we have to assess them, and we have to select some of them for the awake videolaryngoscopic intubation. The seventh and last point is that it is important anyway to maintain a low threshold for a WOC procedure in order to ensure high quality and confidence in managing complex airways. Thank you, everyone. I'm available for any questions if you need. Thank you a lot.